Hello people, in this video we want to look at stridor. So basically what is stridor? It's noisy respiration produced by turbulent airflow through the narrowed air passages. So first of all, narrowed air passages. So here you can see the air passages, right? So these will become narrow. So what will happen if these become narrow? Right? They become narrow, and that time there will be noisy respiration, which is called as stridor. And why is there stridor? Why is there stridor? Because in this narrow path the air has to go, right? So instead of the air going like this, it is going like this. So turbulent airflow is causing what? Stridor. What is stridor? Noisy respiration due to turbulent airflow through the narrowed air passages. So this much we have got. Let's listen to a stridor sound. So did you hear that, guys? Guys, there's yet another terminology called stertor, which is snoring. So don't get confused with stridor and the stertor, okay? So what are we looking at in this video? Stridor. So let us look at the types and classification. There are many ways of classifying. So you have inspiratory stridor, which is during inspiration, obviously. Then you have expiratory stridor, which is during expiration. Then you have biphasic stridor, which is there at both inspiratory and expiratory. So can you tell the types? Yeah, so which are the types?
Inspiratory stridor, expiratory stridor, biphasic stridor.
Very good. So let us look at inspiratory stridor. It is produced when the obstruction is there here. See, inspiratory stridor is here. Wait. Inspiratory stridor is shown here if it is above the glottis. So the glottis is at this level. So if it is above the glottis, that is supraglottis, or if it is at the pharynx level, it will produce what? If the airway is narrow here, then there will be inspiratory stridor. Okay. So that is inspiratory stridor. You finished that. So when will you see that? You will see that in acute epiglottitis, etc. When there is problem with the supraglottic structures like the epiglottis and all that, right? So in laryngomalacia, what is affected? Actually, the epiglottis will be omega shaped, remember? Then retropharyngeal abscess, all that is pharynx, right? So obviously it will cause inspiratory stridor. So you got inspiratory stridor, right? Then coming to expiratory, let us look at expiratory. Expiratory is when it is from this level. Wait. It is from this level, that is thoracic trachea and bronchi. Which type of trachea? Thoracic trachea. Here above you have the cervical trachea, not that. Thoracic trachea and bronchi, if they are causing, if they are narrow, then there will be expiratory stridor. So this is the lesion of thoracic trachea, primary and secondary bronchi, etc. will produce expiratory stridor. Guys, focus here. What are we looking at? Expiratory stridor. Yeah. So why will this happen? If there is a foreign body in the bronchi, right? Bronchial foreign body, or if there is tracheal stenosis, that is narrowing, right? Then you will have expiratory stridor. Then what about biphasic stridor? Biphasic stridor, when will you see, guys? So obviously somewhere in between you will see both. Biphasic stridor, that is here. So biphasic is where glottis, that is glottis here, subglottis, and also the cervical trachea. Which are the three parts which comprise the areas that give biphasic stridor? Can you see it?
Glottis, subglottis, and cervical trachea.
Very good. So guys, let us look at what exactly can happen here. So here, if what and all can happen, something to do with the vocal cord paralysis can happen, laryngeal papillomas which are there where on the vocal cord only, right? Then subglottic stenosis. Subglottic stenosis means there is narrowing here in the subglottic region. So that will cause biphasic stridor. Laryngeal papillomas, when did you see? That is in human papilloma virus infection, isn't it? Do you remember this photo? The papilloma, laryngeal papilloma. So guys, shall we move on now? Let us look at another classification of stridor. So stridor you can also classify as congenital or acquired. So congenital can be laryngomalacia, that is that omega shaped epiglottis, right? Laryngeal web, where between the vocal folds, you have this web membrane kind of a thing which will cause stridor, right? Then subglottic stenosis, narrowing of the subglottis. Now in children, which is the narrowest part of the larynx? Subglottis, right? So subglottic stenosis will be even more narrowing. Hemangioma, some growth happening there. Vocal cord paralysis, so vocal cord has paralyzed. So let us say they are in the medial position, right? The median position, so they are not getting abducted. So if there is a narrow airway, then again vocal cord paralysis can cause stridor. Tongue and jaw abnormality. Actually, if you see tongue abnormalities that cause stridor and mandible abnormalities that cause stridor, let us look at this. Tongue abnormalities can be cretinism, that is hypothyroidism, right? Hemangioma, lymphangioma, dermoid lingual thyroid. Mandible, they're talking about a small mandible, micrognathia, Pierre-Robin syndrome. What is that? This is just a case where the child will have a smaller lower jaw. That's it. Okay, Pierre-Robin syndrome. Okay, and why is there stridor in these cases? Because of the following back of the tongue. Okay, so you understood why tongue and mandible we have come. So where are we? Okay, we are here. So we finished the congenital part of it. Okay, congenital, what and all will you say? If somebody says what are the congenital causes of stridor, quickly you should tell. Laryngomalacia, laryngeal web, micrognathia, Pierre-Robin syndrome. Then what else? Subglottic stenosis, hemangioma, vocal cord paralysis. Remember, in the larynx of the child, the narrowest part is the subglottic part, right? That's why it has got a funnel-shaped larynx, right? Where it is very narrow in the subglottic part. So that you can remember. Then coming to acquired, guys. Acquired. Now we are moving to what?
Acquired causes of stridor.
Yeah, very good. So acquired is divided as afebrile and febrile, guys. Afebrile means this person has no fever, right? So he's having some other issue but not fever. So he can have those papillomatosis you just now saw, right? JORRP. What is that? Juvenile, is it? Juvenile papillomatosis, recurrent respiratory papillomatosis. Right? What is O here? Okay. So where are we here? So, you know, papillomatosis, afebrile, because that is something to do with some growth on the vocal fold. Basically, they are saying it's a benign tumor of the larynx. Okay, it's benign only. Though they have put it neoplastic, it's a benign neoplasm. Okay. Going back, guys, where are we? We are looking at the afebrile causes of stridor. Then you have injury, foreign body, all the standard things you write. Okay, injury, foreign body, you should write. This is not at all causing fever or it's not congenital, it's acquired. Then you have laryngeal edema. So the larynx has got edematous, right? So then you have adenotonsillar hypertrophy. The adenoid tonsils, guys, here in your nasopharynx, this has got hypertrophied. So what is it causing? Narrow airway. So obviously it is causing stridor, acquired stridor, afebrile. Okay, very good. Then let's move on. Let's keep this photo handy. Then coming to febrile. Febrile, what and all will you say? Obviously infections, right? So infections like what and all will you say? Epiglottitis, laryngitis, all put itis. Epiglottitis, laryngitis, laryngotracheitis. Then okay, one infectious mononucleosis. This is because of Epstein-Barr virus, isn't it? Then what else? Diphtheria because of Corynebacterium diphtheria, retropharyngeal abscess, peritonsillar abscess, all the deep neck space infections you will write. All that will cause narrowing of your airway, and that is febrile cause. All are infections. Name the viruses here. Infectious mononucleosis virus, everything else is bacteria only, right? Most of it are bacteria. Peritonsillar abscess, mainly what will you blame, guys? You will blame Streptococcus, Staphylococcus, similar organisms only you will blame everywhere. This epiglottitis, you have to blame Haemophilus influenzae B. Okay, this one you have to remember. This is Haemophilus influenzae B. Okay. Here peritonsillar, Streptococcus, Staphylococcus. Okay. Corynebacterium diphtheria here. Infectious mononucleosis is Epstein-Barr virus, right? That is herpes virus, DNA virus 4. But remember, all these are infective, but look at this one. This is infective, papillomatosis, because of human papilloma virus. But here it is not a febrile condition. Though this is infective, this is not under febrile. Guys, we have to cover a lot, right? So let's just go a little fast. Let's see nose. If there is, because of nose, why can there be stridor? Because if there is choanal atresia in the newborn, that is that at the back of the nose, there will be that membrane, right, which will not allow the air, or I think in this case some partial air is going. That's why it is causing stridor. Then coming to tongue. Tongue we saw because of macroglossia. Macroglossia, big tongue. So big tongue, guys, so big tongue will block the airway. Mandible has to be small, so there is a very small airway. You saw this Spear-Robin syndrome, etc. Then pharynx, what will be there in pharynx, guys? Can you think about what will be there in pharynx? Pharynx is here, right? So in pharynx, what and all can be there? Congenital dermoid adenotonsillar hypertrophy that you saw already. At the back of the nose, you saw the adenoids which can become big. Retropharyngeal abscess, tumors, some tumors can be there. So all that can cause stridor. Coming to larynx. Now larynx starts here, right? From your, okay, let's say from the epiglottis. Then this is the glottis, right? So larynx congenital, there can be laryngeal web, laryngomalacia. You saw laryngomalacia, did you see here? They have shown laryngeal web between the two vocal folds. There is a concave kind of membrane, right? So this is laryngeal web. This can cause stridor. This is the laryngomalacia, the very flexible epiglottis has become omega shaped. So it's going to be so narrow, and there will be stridor. What type of stridor? Yes, it is at the glottis level. So it will be inspiratory stridor, right? Oh, glottis will be biphasic. Guys, so one of them is, see, this is epiglottis. So this is supraglottic structure. Supraglottics, what did you see here? Inspiratory. Then coming to glottis. Glottis is at same vocal fold level. So here what stridor you will have? Biphasic. So here you will have epiglottis, you will have inspiratory stridor. And in laryngeal web, you will have biphasic stridor. Subglottic stenosis, again you will have biphasic stridor. Vocal cord paralysis, that's at the glottis, yes, biphasic stridor. Then some cysts can be there. Where is it positioned? Depending on that, the stridor will be there. Inflammatory, guys, so you have already seen the febrile conditions, epiglottitis, laryngotracheitis, diphtheria, tuberculosis they have added here. Just remember, this is inflammatory. Okay, inflammatory they are saying, and okay. Neoplastic hemangioma, juvenile multiple papillomas, that is that recurrent laryngeal papillomatosis. So this is, what did we see? Carcinoma in adults, okay. Some carcinoma, and also you add laryngeal carcinoma. What else will you see? Traumatic, always say trauma, foreign body, always you have to write, remember all this. Then edema following endoscopy. They were doing endoscopy and there is edema following endoscopy. Prolonged intubation, they intubated the person, prolonged, so all these are some kind of a iatrogenic kind of a thing, right? Neurogenic, laryngeal paralysis due to acquired lesions. Paralysis of the larynx due to some acquired lesions. Where exactly are we? What are we looking at? Step by step, level by level, we are looking at the causes of stridor. We have reached where now? Larynx we are in. So laryngeal carcinoma, injuries to larynx. Remember guys, larynx means you have everything here like supraglottis, glottis, subglottis. So you can have inspiratory and biphasic stridor for laryngeal causes, okay? And write everything. What will you write? Congenital, what can be there? Then afebrile causes, then febrile causes, write all this, okay? Then let's move on to trachea and bronchi. Trachea and bronchi, again trachea has two types of stridor. See, trachea, cervical trachea will have biphasic stridor, thoracic trachea will have expiratory stridor, okay? Bronchi only expiratory stridor. So what are the causes? If somebody asks, what will you say? Causes. Move here. It's refusing to move there. Okay. Congenital, there can be atresia, stenosis, tracheomalacia. There's a tracheomalacia, okay? Inflammatory, blame some tracheobronchitis. Guys, pay attention. How's it going? What are we looking at? Trachea and bronchi, okay? Neoplasm, always trauma, blame some foreign body. After prolonged intubation, tracheostomy, okay? Trachea, tracheostomy, okay? Lesions outside of respiratory tract also can cause, okay? This is something extra for us. Lesions outside of respiratory tract means vascular rings cause stridor and dysphagia. Like esophagus also they are blaming here. Esophageal atresia. Tracheoesophageal fistula can cause a stridor because the air is going from the trachea into the esophagus or what? Congenital goiter. So because of this thyroid issues, maybe that is causing a narrow airway. What do you say? Cystic hygroma. What is cystic hygroma? This is basically blockage in the lymphatic system. So there's some fluids filled sac. So that is why maybe there is obstruction or something, right? Lymphatic obstruction it is. Okay. Then inflammatory lesions which are outside the respiratory tract. Retropharyngeal space infection, that is retropharyngeal abscess, retroesophageal abscess. Traumatic, there can be FB esophagus. What is FB? That is foreign body, is it? Foreign body of esophagus, is it? Secondary tracheal compression it will cause. Masses in neck. Neck masses also can lead to constricted airway causing stridor. I think we have studied a lot of etiology on stridor. What do you say, guys? Okay, so we have finished etiology. Now we have to move to what? Management. Management. In management, first of all, they're telling history, okay? You have to take proper history. Then you have to do physical examination. Then you have to do what? Investigations. And then you have to do treatment, okay? Treatment, nothing much as this, guys. Same thing, history, examination, same thing, airway resuscitation, mini tracheostomy if they need the airway to be managed. We'll go super fast from here. Pay attention. History, what will you ask? Time of onset, mode of onset, duration, relation to feeding, crying. When it cries, what will happen? That also you should find out, right? Because in laryngomalacia, the crying will be normal, but the stridor increases on crying or something, right? Then aspiration, is there any history of foreign body? Cyanotic spells, is there any cyanotic spell episode? Okay, then is the baby able to feed? What else you want to know? Laryngeal trauma, was there any trauma? All the history will ask. Then physical examination, what will you do? So what are we moving to now, guys? Physical examination of what? Stridor. Stridor can be associated with respiratory distress. So there may be recession in the suprasternal notch, sternum, intercostal spaces, epigastrium. When they are trying to breathe, there will be all this recession. It's going inside, right? Then what else? When stridor is inspiratory, expiratory or biphasic, it indicates, yeah, when you know whether it's inspiratory, you're hearing it during inspiration or expiration or biphasic, you know where it can be coming from. Then whether there is snoring sound along with it, whether there's gurgling sound along with it, whether there's a hoarse cry, because you remember in cry is normal in laryngomalacia and subglottic stenosis, they are saying, okay. Then expiratory V is bronchial obstruction. A bronchial obstruction will cause expiratory only. That much we know, right? What are they trying to tell here? What do you think they're trying to say here? Anyways, we are moving on. We'll try to close this. Associated fever will include whether it's an infective condition, laryngitis, epiglottitis, laryngotracheal bronchitis, diphtheria, etc., etc. Then Epstein-Barr virus, that they didn't tell you, infectious mononucleosis. Okay. Then stridor of laryngomalacia, micrognathia, acroglossia, innominate artery compression. When the baby sleeps in prone position, in laryngomalacia, what will happen when it sleeps in the prone position, that is, it is sleeping on the stomach, the epiglottis will come down to the ground, so it can breathe better, right? So the stridor will disappear when the baby lies in prone position. In what? In laryngomalacia. So look at this, guys. This is prone. So what happens when they are prone? The epiglottis will be here, down. So they'll be able to breathe. What do you think? Correct? No, what we are saying. What are we looking at? The physical examination for stridor. Okay, then sequential auscultation, you can, when you hear with stethoscope, etc., you will be able to localize the probable site of stridor. Okay, stethoscope, use stethoscope. Then examination of nose, you examine everything, the nose, tongue, jaw, pharynx, larynx, etc. Till larynx you can examine, I think, right, with indirect laryngoscope, etc. Till there you can examine. After that you will have to go deep inside, you'll have to check other things. Indirect laryngoscopy can be done easily in adults, but in children, infants and children, they will require flexible fiber optic laryngoscopy. What is that? So they are putting some topical anesthesia and then they are doing this. Okay, flexible fiber optic laryngoscopy. They're checking the larynx. They have put some light here and they're checking the larynx. So if there is some laryngeal web, they can see it, right? They're saying they will do this for everything. Laryngomalacia, vocal cord paralysis, papilloma, everything. But they're not talking about that epiglottitis, because epiglottitis, they should not do anything, right? Because the child will be breathing with a lot of difficulty. Yeah, then that's what they say. In epiglottitis, acute epiglottitis, you should not examine the throat. See, we have written here, avoid examining a child's throat when epiglottitis is suspected. Epiglottitis is suspected. They'll have to do X-ray or see the thumb sign, etc. They have to give antibiotics because the child will be leaning forward and sitting so that it can breathe. Okay, just 2 more slides here. Investigations, what will you do? You will do lateral x-ray and all that, chest x-ray, neck x-ray. Okay, in inspiratory and expiratory phases, they are trying to check. They're checking for foreign bodies, CT scan they're doing for mediastinal masses, for congenital vascular abnormalities, angiography they're doing, for vascular anomalies, esophagogram they're doing, okay. So what and all, can you tell what and all they're doing? They're doing X-ray, CT, esophagogram, angiography, all this they're doing, okay. CT scan, that's it. X-ray of what and all they are doing? Lateral, neck, posterior, anterior view of neck also they're doing. Chest X-ray they are doing, right? They're doing lateral and PA view of neck, depending, okay? Then let's see, this is direct laryngoscopy they are saying. When will you do this? See, one thing in these people who have stridor and all, you should monitor the oxygen saturation, right? It's important to monitor the oxygen saturation, pulse, blood pressure, etc. This direct laryngoscopy, why do they do? Looks like they are trying to get some secretions and find some culture sensitivity, crust, foreign body if they can remove also. So something like a treatment it is. Then treatment, exactly what they're saying is you check the cause and plan, okay. Same thing they're telling, history, examination, active resuscitation, tracheostomy, intubation, tracheostomy, mini tracheostomy, etc. Mini tracheostomy is what? Cricothyroidotomy. So that's it guys. In this video we had to look at stridor. So we have taken a very deep insight into stridor. Noisy respiration produced due to turbulent airflow through narrowed air passages. Then we saw that you should not confuse it with this other term for snoring. Classification, inspiratory stridor, biphasic, expiratory, based on the location itself you can tell. Then you have congenital, acquired, again you have afebrile and febrile causes. Then you saw the same thing based on location, nose, tongue, what and all can be the reasons for stridor. Then we saw the management, you'll take the history. Then you will do physical examination, don't do examination and if you're suspecting epiglottitis. Then flexible fiber optic, examination you don't do means don't do throat examination, okay. Then flexible fiber optic laryngoscopy you will do under topical anesthesia, especially children and infants. Investigation, same X-ray, neck, chest, CT scan, angiography, esophagogram. Direct laryngoscopy, they can take secretions, remove foreign body, etc. Treatment, based on the cause, they will do the treatment. That's all for now in this video on stridor, guys. Bye bye.